Takotsubo cardiomyopathy, often called broken heart syndrome or stress-induced cardiomyopathy, is a fascinating clinical entity that mimics an acute myocardial infarction but typically occurs in the absence of obstructive coronary artery disease. The most widely accepted mechanism is a catecholamine storm. High levels of circulating epinephrine and norepinephrine lead to epicardial or microvascular vasospasm. High concentrations of catecholamine can be directly toxic to myocytes, likely through calcium overload. A switch in beta-2 adrenoceptor signaling from GS stimulatory to GI inhibitory pathways, which protect the heart from toxicity but results in profound localized negative inotropy or stenting. While the classic trigger is an emotional stressor like grief, anger, or fear, physical stressors like stroke, surgery, and asthma exacerbation are actually more common and often carry a worse prognosis. No trigger may be found in nearly 1/3 of patients. Most cases occur in postmenopausal women, suggesting an estrogen deficiency component that sensitizes the myocardium to stress. In the International Takotsubo Registry of 1,750 patients published in NEGM, 89.8% were women and the mean age was 66.8 years. Symptoms of chest pain and dyspnea are often indistinguishable from acute coronary syndrome. Diagnosis is often made in the cath lab when a patient with STEMI-like ECG changes shows clean coronaries. Key features include wall motion abnormalities, transient dyskinesia of apical and mid-ventricular segments resulting in the octopus trap shape, apical ballooning. ST segment elevation, usually V2 to V5, followed by deep symmetric T-wave inversion and QT prolongation. Moderate elevation of troponin, which is often disproportionately low compared to the extent of wall motion abnormality. BNP and T-proBNP is typically significantly elevated. While apical ballooning is the classic form, other variants exist. Mid-ventricular, involvement of mid-segments only. Basal, inverted Takotsubo, sparing the apex, often seen in younger patients or secondary to pheochromocytoma. Focal, limited to a single segment. Though ventricular function usually recovers in 1 to 4 weeks, the acute phase can be life-threatening. Focus on managing left ventricular outflow tract obstruction, which occurs in 20% of patients due to basal hypercontractility. The hyperdynamic base creates a Venturi effect, pulling the mitral wall leaflet into the left ventricular outflow tract. In such cases, avoid inotropes if LVOT obstruction is present. Use beta blockers cautiously and intravenous fluids instead. Phenylephrine may be needed if hypotensive. ACE inhibitors or ARBs are often used to aid remodeling, though the evidence for long-term beta blocker use in preventing recurrence is surprisingly mixed.